Good evening, everybody. So I thought that bringing saltwater taffy was a great idea. Goes with my topic. I asked my husband, do you know where they are? And he goes, oh, I think Ishan ate it. And Ishan is 2. He ate all of them, so anyhow, I couldn't find them, but let's start our topic. As Dr. Ayler put it really perfectly, that talking about, I thought that this topic was great because we see a lot of exposures related to water activities, and so our objectives today will be to identify certain infections that are related to freshwater and saltwater exposures. There's a vast variety of organisms, but I thought that I'll just discuss few important ones that we may come across as being ID physicians or otherwise. So I'll discuss mainly the risk factors associated with each organism, clinical manifestations of that particular disease, and the treatment options that we have. So we're going to talk about pretty much all of these classes, and the bacteria. As you can see, there's a lot of them. There's a lot more. I thought something interesting to talk about was sea bathers, eruption, and a swimmer's itch that we may on and off see, and a fungus related with swimming, Lobomycosis, and hepatitis A, which we all know about. How can you get these infections? Basically, the soft tissue infections like cellulitis or abscess, necrotizing fasciitis, and other things, you can get, they can occur after freshwater and saltwater exposure. The trauma that occurs is with the fish hooks and the fish spines. That can be the portal of entry for these bacteria and other organisms that we're going to talk about. The patients can get lacerations with the propeller blades of the boat, and then you can also have bites from the fish, alligators, crocodiles, sharks, and turtles. In U.S. in particular, we have increased consumption of raw and undercooked seafood, and we do a lot of recreational water activities. And there's a lot of travel to tropical areas as well, so we see a lot of infections related to these types of exposures. So I thought that just simplify them into freshwater and saltwater. The freshwater includes Strep inae, which is a bacteria, Mycobacterium Marinum, Aeromonas, Plesiomonas, Edwardsiella Tarda, and Lobomycosis. The saltwater, you can also get Mycobacterium Marinum from saltwater exposure, but basically all the Vibrios, and Shuanella, which we'll talk about. So, Vibrio species. When I was reading about them, I thought it was pretty interesting that after Hurricane Katrina in August 2005, there was about 22 new cases of Vibrio infections in Louisiana and Mississippi. That's the most affected states from that. And Vibrio Vulnificus alone caused about 82% of those infections, the wounds. So Vibrio Parahaemolyticus is usually the most common species of this Vibrio family, or the non-cholera Vibrio family, so to speak. And but interestingly, Vulnificus is the one that causes the most mortality, about 94%. So although you'll see Parahaemolyticus as being the most common, but you'll see a lot of mortality from the Vulnificus. So it's very important to identify it early enough and treat. So CDC reports about 8,000 Vibrio infections, and I put that down just to see the ratio. You can see that there's, out of 8,000, about 100 of those are Vulnificus, and about 4,500 are Parahaemolyticus. And usually, annually, there's about 100 deaths related to Vibrio infections. So what does Vibrio species usually do is that they produce a lot of cytotoxins and a lot of enzymes that causes the tissue damage, and that's when we see the lot of mortality from. So the first one in that family that we'll talk about is Vulnificus. I saw my first case of Vulnificus on the first day of fellowship, and I thought that was pretty interesting. That was a really great exposure. And it's usually part of the normal marine microbiota, and it's Vulnificus it accounts for about 90% of seafood-related deaths in the United States. And where you usually see those Vulnificus-related infections is in the states bordering Gulf of Mexico, New England area, and northern Pacific regions. Most infections, they occur in the summer months, which are April to October, and the reason is because Vibrio likes the warmth of the water during those months, and it likes the salinity of the water, and that's why it stays and it grows and it causes more infections. The highest fatality rate is in liver disease. We all know cirrhotic patients, iron overload states, and the iron part of that is related because Vibrio likes the way it works and causes disease. It needs iron to replicate and all. So, as you can see in that picture, the man carrying the fish, and it's a shallow salt water, and that's how the patients who come in, they get the wounds through the salt water. The occupation that's highest at risk is a dock worker, an oyster shucker, and a commercial fisherman. And those are the occupations to keep in mind when we think about, when we look at the wounds and we ask them their occupations. You can also get the Vulnificus from consumption of raw or undercooked seafood, and the major seafood that you get that from is oysters, clams, crabs, and mussels. You can also get it through fish hook and fish bone injuries, the punctures through crab or lobster, and also you can get it from stepping on oysters. So you can see the oysters in that picture. The clinical manifestations of Vibrio vulnificus is it can range from being mild and very self-limiting to being severe. The initial complaint of the patients is they get severe pain and swelling in the body part that they get the wound from, and then it just progresses very rapidly. So if the patient has underlying liver disease or iron overload state or immunocompromised state, they can progress that simple wound to very bad looking hemorrhagic bullae as well as extensive soft tissue necrosis. So they can get the necrotizing fasciitis, myonecrosis, and other sequelae of that. And that's an idea of what it looks like, the hemorrhagic bullae on the left, and then you can see the big picture of the bullae and the necrotizing fasciitis in that left foot there. So if you see something like violaceous, purplish looking, these kind of bullous lesions, you should suspect vulnificus. Now, treatment-wise, so you can either culture the wound itself superficially, or the bullae, you can take a culture from that and send it, and I was reading that you should always send the isolates of vulnificus to a public health lab. Blood cultures are usually recommended if the patient is septic, has a fever, and they have other signs of sepsis. The antibiotic that usually we recommend is doxycycline, and you should use, in addition to doxy, a third-generation cephalosporin. You can also use a fluoroquinolone, but I would just prefer the doxy and a third-generation cephalosporin. The necrotic tissue should be debrided, and if it is severe, then the patients may even need fasciotomy or even amputation. So the way you can prevent it is usually, you can report these vulnificus to local FDA or CDC, and they can sample the water area where the patient came from and you can reduce the infection rates there. And interestingly, it doesn't alter the taste or appearance of the oysters, so try not to eat raw oysters. Alginolyticus is another Vibrio family, and it's halophilic, which means it needs salt water to grow. And what it is, it's a gram-negative curved rod like Vibrio family, and as I said, it requires salt water to grow, even in labs. So the risk factors are basically saltwater exposures and brackish waters, and it's usually in younger patients and patients without any underlying disease. So compared to Vulnificus, it's a little different. And what usually happens is that this particular bacteria is related to coral reef injuries. So if you happen to be diving or happen to hit your extremity with the coral reef, you can get this cellulitis, and it's also associated with otitis media and externa. So it can cause necrotizing fasciitis like Vulnificus, but it's usually the more milder cellulitis. It's not as severe as the Vulnificus family. The treatment options are tetracycline, gent, Bactrim, and chloramphenicol for Alginolyticus. Parahaemolyticus, it was first recognized in 1953, and it's another Vibrio family, and it's also halophilic, so it requires salt to grow. It's limited to Gulf Coast, so I thought that it was good to just see the states that are around the Gulf area, so Mexico, Texas, and Florida, New Orleans. So we're there too. And Atlantic seaboard is on the right. You can see all the states. It goes all the way to the East Coast. So all that is the Atlantic seaboard area. The Gulf Coast states, what's important with them is that they have low salt. They have warmth for these bacteria to grow, and that's why you tend to see more infections in those areas. The risk factors with this one is you can get it through shellfish as well as oysters, and of course saltwater exposure. So with Vibrios, I would just say saltwater exposure is the key, and the seafood, oysters. The clinical manifestations of Parahaemolyticus is they're a little different than the other two. It usually tends to cause a diarrheal illness, and so they have watery diarrhea, a lot of abdominal cramping, nausea, vomiting, fevers, and chills. So that's the kind of syndrome they have when the patients present. So when you suspect is usually if a patient has some sort of saltwater exposure, they ate some raw seafood, and they have this diarrheal illness, then that should be in the back of your mind to think about Vibrio Parahaemolyticus. There's no treatment for this particular bacteria, but they say that if they are very severe and you see that in the stool culture that it's Parahaemolyticus, you would give them tetracycline or a fluoroquinolone such as Cipro. But the evidence says that the antibiotic treatment really does not really shorten the course or the severity of the disease. So mainly supportive care. So we'll jump to Mycobacterium Marinum. It's an intermediate growing bacteria, Mycobacteria. So we know the rapid growers, Mycobacteria. This one is the intermediate growing. It is in the atypical Mycobacterium family, and it's in the Runyon 1 group for the ID people. Just some extra info there. And basically the Runyon 1 group, they are called photochromagen, and this particular marinum, it produces a pigment when it's exposed to light, and it's a yellow pigment. That's why it's under that class. It's the most common cause of external granulomas on the skin, mostly in the fish handlers and the aquarium workers. So those are the buzzwords for marinum. The skin infections are typically called tropical fish granuloma or fish tank granuloma, so they tend to appear on the boards sometimes. Before 1962, we had the issue in U.S. of the swimming pools were not so chlorinated, and so we used to see a lot more marinum-related granulomas, granuloma infections on the skin. After 1962, chlorination sort of kind of took away that risk factor, and so after 1962, the most of the acquired marinum was from cleaning aquariums. It's very rare in U.S. That's what the readings that I was doing was mentioning, and usually it's related with either of fresh or salt water. So it's either or. And it is very chlorine resistant, and so that's why if you chlorinate your swimming pools and there's enough chlorination, then you will not tend to see the Marinum infections. The individuals, the occupations who are at increased risk for this particular bacteria class is the fishermen who are handling the fish, the saltwater aquariums, the home aquarium owners as well, and especially the immunocompromised individuals who can get a very progressive infection with this. So how does it start? Usually it manifests like a very mildly tender papule, and then it just becomes bigger. It can ulcerate. It can have pus. It usually prefers. The interesting thing is it prefers a certain temperature to grow, and so it's usually seen in cooler extremities, such as in the hands, usually in the distal extremities, and more often you see that more often than in the central area. So you'll usually see it on the hands. Dissemination is very rare, and usually the infection starts with the wounds in the non-chlorinated water. It's also a very major cause of persistent ulcer, draining sinuses. So you should always keep that in mind, as in the back of your mind. If you see chronic ulcers, Marinum should be one of your differentials. It can cause extensive osteo as well, which can cause amputation of the involved. Oh, sorry, what just happened here? So this is how it can usually start, just as a tiny tender nodule. It can progress. On the right, if you can see a series of nodules, and that's like ascending lymphangitis sort of. It can happen like that too. The treatment is very it responds really slow to antibiotic therapy, and you can require treatment as little as 2 weeks up to 18 months. Some studies show that sometimes patients may need about prolonged course, like 3 to 4 months of therapy. In terms of the antibiotics that you can use minocycline, clarithromycin, doxy, Bactrim as a monotherapy. If they have really severe infections, usually you use rifampicin along with ethambutol. So I thought this was something important to mention. The Marinum infection should always be included in the differential diagnosis when you see poor healing wounds, chronic draining sinuses, and they have a history of exposure to aquariums. So Erysipelothrix Rhusiopathiae, it actually, the bacteria itself does not infect the fish. It lives in their slimy layer, basically. It's a gram-positive rod, and it's widespread in nature. It infects both domestic as well as marine animals. The infection in humans is caused by occupational exposure. The occupations that you should keep in mind are fishermen again, aquarium workers, farmers, vets, and slaughterhouse workers. So they're all at risk for getting this infection. So this one has kind of an extensive manifestation. So it can either present as a localized cutaneous infection, which is called erysipeloid. It can also present as diffuse cutaneous infection and a systemic infection. So we'll talk briefly about all those three. The localized infection is a subacute cellulitis. They tend to get just some pain. There's a small red macule, and they can also get some localized lymphadenitis. The diffuse reaction is they get all over urticarial lesions, and they can also get fevers and joint pain. And this kind of reaction they usually get by eating some contaminated seafood or undercooked pork. The systemic infection is usually uncommon, and they have fever, but it can cause endocarditis. And something that was kind of interesting was that it usually causes aortic valve endocarditis predominantly. It can also cause brain abscess, meningitis. You can have intra-abdominal abscess. So when do you usually suspect it is if they have appropriate epidemiologic exposure, and if they have those kind of findings. You can also usually this organism, you cannot culture that from a superficial swab or cultures because it's deep in the dermis. The blood cultures can become positive, but they are sometimes misidentified as lactobacillus or enterococcus. So again, history taking will be important and seeing if they have any sort of exposure. So for this particular bacteria, penicillin is the drug of choice, and it's inherently resistant to vancomycin. But some studies have shown that you can use daptomycin and Zyvox. So again, it's a gram-positive rod, and so if you have some cellulitis and you're suspecting, staph or strep, and you start vancomycin and you don't see, any improvement, then maybe if they have some exposure, think about Erysipelothrix, and maybe that's why they're not responding to vancomycin. So this was something from Up to Date. So preferred, the drug of choice is penicillin, and vancomycin they're usually resistant to vancomycin. So Strep inae is again another gram-positive bacteria. It's in the Streptococcus family. And it was initially identified in 1976 as abscesses in the dolphins in U.S. aquariums. So back in 1976, this was identified as the cause of the dolphin abscess. Now it's a major fish pathogen, and the one thing that's important to know is that you can get that from handling a live or killed fish, usually tilapia. And it's associated with freshwater exposures, as opposed to Vibrios, which are saltwaters. So the primary site is the cellulitis of the hand, and you should take precautions when you handle especially tilapia, especially for immunocompromised patients, because they can get this infection easily by handling or filleting the whole uncooked fish, if the fish itself is infected. Edwardsiella Tarda is the gram-negative rod, and it's in the family of Enterobacteriaceae. It's a notorious fish pathogen, and usually with the catfish. So you can see the catfish there. And if the catfish punctures, there's an inoculation, and you can get this bacteria from there. It's the skin disease is very uncommon with this pathogen. You tend to get more of the enteric disease, like diarrheal illness. It can cause wound abscesses at times, and it's worse in patients with the underlying liver disease. So treatment options you have is penicillin, cephalosporins, and fluoroquinolones. Shewanella is another gram-negative rod, and the putrefaciens is the only serovar that's very important for human disease. Among Shewanella species, there's another species, Shewanella algae, which doesn't tend to cause human disease a lot. So they form yellowish-brown mucoid colonies, and they have a fish-like smell, and that's why they're called putrefaciens. The diagnosis is usually by blood or the lesion aspirate cultures. It's a very unusual cause of disease in humans. It tends to cause the disease in the marine animals, the fish. As you can see there, the fish has a little cellulitis going on there. You can get it from ingestion of the raw seafood and freshwater and saltwater exposure as well. When they cause disease in humans, is usually deep ulcers with hemorrhagic bullae, and something interesting was that it's usually in association with chronic ulcers or after burns. If somebody has had exposure to sea or saltwater, freshwater, the bacteria tends to live in the denuded skin, and then you can get the infection after that. So it can sometimes cause bacteremia as well. With Shewanella, the issue is they're resistant to penicillins, but they're sensitive to aminoglycoside, and interestingly, they are sensitive to third-generation cephalosporin and fluoroquinolones as well. So if you have an invasive infection like a bacteremia and they're looking very sick and you're suspecting that, you would tend to use 2 weeks of IV antibiotics, and you can do 2 to 4 weeks of oral antibiotics after that. Aeromonas, another gram-negative rod. It produces a lot of enterotoxin, causes diarrheal illness, and also hemolysin. The one serovar that's very important with Aeromonas is the hydrophila, and that's the one that causes most often human infections. It was very common in the tsunami victims in 2004 and also in Hurricane Katrina. So this is a freshwater organism. It's sometimes recovered from chlorinated tap water and hospital water supplies. There's a lot of case reports that mention that. It is a warm month disease again, and usually, as I said, the soft tissue infections are more so from the Aeromonas hydrophila, the serovar. The clinical manifestations, the way you get this exposure, this bacteria, is usually through the propeller injuries again, and also leeches. The medicinal leech attachment that can this bacteria lives in the foregut of the leech, and then once some people use that for medicinal purposes, the leech can get the Aeromonas can get in and cause local wound infections. Alligator bites have been associated with Aeromonas and mud football. There was a case series of I forget how many patients in Australia back in 1970s that they were all exposed to they were all in the mud football, and pretty much all those had Aeromonas related wound infections. It typically involves an extremity, and the systemic signs are usually common with this one. It can cause necrotizing fasciitis, and also it usually can cause this bullae skin lesions, as you see on the top there as well. They are resistant to penicillins because they produce beta-lactamase. They're very active. They're highly active to fluoroquinolone, and as a matter of fact, some patients who do the medicinal leech, they are given fluoroquinolones prophylaxis just to prevent Aeromonas wound infections. And they are seeing a lot of fluoroquinolone resistant following leech therapy, probably because of that reason, that they're using it a lot to prevent that. Plesiomonas is another freshwater, which the name Plesiomonas comes from the Greek word which means neighbor, because initially when it was isolated in 1947, it was thought to be closely related to Aeromonas, so they gave that name Plesiomonas to it. It's usually in fresh water, but you can also get from foods such as oysters, shrimp, or chicken. And the treatment is it's susceptible to chloramphenicol, Bactrim, and fluoroquinolones as well. It's resistant to penicillin. Skip that. Chromobacterium violaceum is a gram-negative rod, and the name violaceum comes from the violet color colonies that it makes when it's grown on the culture. And it's a very rare human pathogen, but when it does, it can cause life-threatening sepsis. The first case was isolated in Malaysia in 1927. And the important thing to remember about this one, the buzzword is chronic granulomatous disease. So Chromobacterium, chronic granulomatous disease. And it's most often tested on the boards. So the risk factors for this one, most cases are seen actually in Florida in United States, but it's all over. There's case reports of this particular bacteria in South America, Australia, Southeast Asia, and it usually enters with skin injury from the fish bite. So the clinical signs are they get an ulcerated skin lesion, and sometimes they can get a bluish pus from the site. And the thing about this one is that the septic shock develops very rapidly. Mortality is about 60%, and they can have abscesses at multiple sites, and usually it's in liver, lungs, and spleen. So this is one of the violaceous necrotic lesion in the post-auricular region associated with this bacteria, and then you can see some abscesses on the PET scan in the liver, as well as some in the spleen, in this right here, and the abscesses. So the interesting thing about this one is that it produces antioxidant pigment. It's called violacin, and that's why it gives that violet color colonies. And the reason it does that is because it protects the bacteria protects itself from the oxidant stress of the host, which is the humans. So these are the beautiful colonies of this bacteria, violet colored. And they are resistant to penicillins, susceptible to tetracycline fluoroquinolones. And actually, azactam is a natural product of this bacteria, but interestingly, they are susceptible to this azactam. Relapse is very common, and you need to drain the abscesses at the sites, like lung abscess, liver abscess, and spleen. The seabather's eruption is called Cnidarian larvae, and it's caused by the stings from these tiny little jellyfishes, and these something happened. These oops. Okay. These jellyfishes, they usually the larvae of these jellyfishes, they sting you, and then you get this particular eruption. It was initially reported in 1949 after swimming actually in Florida, and it is now reported in a lot of tropical and subtropical waters. It's called pica pica in Florida, which is Spanish for itchy itchy. These tiny jellyfish, as I was saying, they release these nematocysts, and they're the ones who are injecting this toxin. The distribution of lesions is usually at the areas where it matches the areas covered by the bathing suit, and you can get them at the pressure points as well. It's not contagious, and the treatment is antihistamines and topical steroids. And they say that the more you take shower, the worse it gets. The swimmer's itch is the sea lice. Yeah. The cercarial dermatitis is the swimmer's itch, and it appears as a skin rash, and it's an allergic reaction to the parasites that actually infects the birds and mammals. These parasites, they are released from the infected snails into the fresh and salt water, and if you go swim there, you can get this particular swimmer's itch. It's frequent during the summer months, and most cases don't require your medical attention. So this is the schistosome, the parasite that's injecting and causing the rash, and it has like these fork shaped in the back. The symptoms are you get tingling, burning, and itching of the skin, and you can also get small blisters. The treatment is usually you can apply corticosteroid cream and anti-itch lotion, bathe in Epsom salts, and other things. Lobomycosis, it's a chronic fungal infection of skin and subcutaneous tissue. It's actually caused by a fungus named Lacasia loboi, and formerly it was called Loboa loboi. It's associated with dolphin exposure. It's very controversial if dolphins can actually transmit this to humans? And I could not really find the answer. The risk factors are primarily coastal southeast US and also Latin America. And it has a very long incubation period. The skin lesions look like keloids. Usually diagnosed with the skin biopsy or KOH prep. The treatment options, they are very poor surgical candidates. It usually doesn't help them. You can try itraconazole and clofazimine, and they recommend about a year of treatment with that for if they have it on the face. You can do cryotherapy and try surgical excision. So that's how the lesion looks like with lobomycosis. It almost resembles a keloid. And if you take a skin biopsy, they're yeast-like structures, and they're in chains, basically. The hepatitis A, we pretty much know the symptoms are fever, right upper quadrant pain, anorexia, and the risk factors are oyster shuckers and sewer workers. You do hep A serologies, and the treatment is usually supportive. The way you can prevent is cooking or boiling shellfish for greater than 60 seconds. And that's my husband and son off of Myrtle Beach. Thank you.